In the introductory video, I mentioned right away that the axial view for CT scans is the best view for almost all facial fractures. As we head into talking about the orbit and orbital fractures, you'll quickly realize that the coronal and sagittal views are actually much more helpful. Usually, we always start off with the coronal view, as it provides a good overview at all the walls of the orbit, as well as adjacent structures, and helps you look for fractures right away. Starting off with our coronal view, our approach is the same. We start from outside the patient's face, or anterior, and begin to scroll until the patient's orbits come into view. Orbital fractures can be broadly classified into two areas. The first type involves fractures of the bony, thick orbital rims, whether it be the superior rim, the inferior rim, or the lateral rim. These three rims are quite thick and involve quite a lot of force to have them fracture. In contrast, the walls of the orbit posterior to these rims are much thinner and thus much more prone to fracture. This includes especially the floor of the orbit and the medial wall of the orbit, which we'll cover later in this video. Once again, starting anteriorly, you always want to examine one side at a time, looking for any obvious fractures of the orbital rims. It's important once again not to be confused by normal sutures. Although we will be covering ZMC fractures in a future module, for example, the connection of the zygoma to the frontal bone can be seen right here. Although this might look like a fracture of the lateral orbital rim, it is in fact a normal suture line, or the zygomaticofrontal suture, ZF. After inspecting the rims on one side, it's important to always remember to scroll all the way back and check the other side. Once again, remember as a general rule, if you see exactly symmetrical lines or what appears to be a fracture on both sides, it is more likely to be a suture line than an actual fracture. After examining the orbital rims, we continue more posteriorly and check out the orbital floors. First on one side, and then on the other. As you examine the orbital floors, remember, it's normal to see the infraorbital groove that will end in the infraorbital foramen anteriorly. This is a normal structure, and although it may look like a slight break in the cortex on either side, remember this is normal anatomy and just represents the infraorbital groove and the infraorbital nerve coursing along it. It's also important to look at your medial wall on each side. This will help you look for medial wall fractures, which are also very common. This concludes our section on orbital wall fractures from a coronal point of view. As you can tell, in the coronal view, it's very easy to appreciate both orbits at the same time and look for obvious fractures. It's important here to see a nice congruent orbital wall and the radiopaque maxillary sinuses underneath. Often one clue of an orbital fracture will once again be blood in the sinus or hemosinus. As we scroll to the sagittal view now, you'll begin to see right away that it's a great view to see orbital floor fractures. Whenever you suspect an orbital floor fracture, you should always make sure to check your sagittal view in detail for any breaks in the cortices and any step-offs you see. Here we see a smooth, contiguous orbital floor with no evidence of fracture. The sagittal view also enables you to see your supraorbital bar, your infraorbital bar, but as mentioned before, its greatest strength is in viewing the orbital floor. Here we can see our radiopaque maxillary sinus full of air underneath and the border between the sinus and the orbital floor. After examining one side, you'll scroll over across to the other side and look at the same things. Once again, making sure to scroll all the way through to look for any potential fractures. And making sure not to get confused by your ZF suture as we discussed before, or internally in the orbit, your ZS suture, which can also look a little bit like a fracture line here. After you are confident there are no fractures in this view, you would then move on to your final view. And contrary to our previous videos and modules, we'll actually be finishing with the axial scan. Although the axial view of the orbits does provide valuable information, right away you'll notice it's not as intuitive as the coronal or sagittal views and is a little bit trickier to navigate. Once again, we'll start inferior, where our maxillary sinuses were, and we'll scroll up. The orbits come into view, and you'll notice it's still good to see our lateral wall here and follow it all the way around. Then we'll scroll back down. We'll do the same thing, but this time we'll look at our medial wall. Remember, after the orbital floor, the medial wall is the second most common area of fracture when it comes to the orbits. Here, we can see our ethmoidal sinuses, their thin walls and septae, and an intact medial wall. We'll repeat the same thing on the other side. Once again, looking at our lateral orbital wall, ignoring the common suture lines that we see, and then scrolling down and looking at our medial wall this time. And right now we don't see any signs of fracture. If you scroll all the way superiorly, you will see, once again, the supraorbital region, and you could observe for any fractures. However, as you can tell, it's very difficult to appreciate the orbital floor in an axial plane. The last thing I'd like to mention is that up until now we've always viewed our CT scans in the bone window. When it comes to orbital trauma, if you are concerned about a retrobulbar hematoma, it can be difficult to see in the bone window. In this particular instance, it's actually useful to use a different window such as abdomen pelvis or head and neck. And as you'll be able to tell, it'd be much easier to see a collection of blood or fluid posteriorly compared to the bone window. It also helps to see your muscles in this view. So, when looking at a coronal view, if you're worried about muscle entrapment, for example in the orbital floor, I would highly suggest switching windows, and you could look at your muscles, whether it be the medial rectus, the inferior rectus. As you can see here, the inferior rectus is an oval shape, and as you may have read, when an orbital floor fracture occurs and the muscle is entrapped, it usually assumes more of a rounded shape rather than the oval shape it is here. Although we use the bone video to view all our facial scans and look for fractures, this is a good example of a time in which switching up the window can help provide more information and make it easier to see if muscle entrapment occurs. Remember, muscle entrapment is a clinical diagnosis and you must confirm it on your patient's physical exam. The last thing I'd like to mention when it comes to orbital fractures is that you need to determine whether the orbital fracture is an isolated fracture or part of a larger pattern. For example, a ZMC fracture, an NOE fracture, or a Lefort fracture. This is something we'll go into more detail on when we review our ZMC and NOE fractures in a future module, but always remember to look at these other structures and determine if there is a common fracture pattern that you are seeing rather than an isolated fracture.